Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Intracellular Therapies, Inc.
Hello, I'm Dr. Manpreet Singh, Professor of Psychiatry and Behavioral Sciences at UC Davis. Welcome to this program titled Recognizing Intersecting Symptoms and Their Implications in Mood Disorders. Joining me today is my friend Dr. Roger McIntyre, Professor of Psychiatry and Pharmacology at the University of Toronto. Let's begin with a question, Roger. What do you say?
Let's do it.
So, we talk about the mood continuum. What is the mood disorders continuum from your perspective?
Yeah, Manpreet, it's something that we talk about in our case rounds, and we talk about this as colleagues. I think it does deserve some type of definition. And I think for me, the way I think about this is that we have the diagnostic manual, the DSM-5 text revision, and we have categories of mental disorders. We're focusing on the mood area today. The reality is that Mother Nature didn't sit at the table with the DSM when they put together the manual. And mental disorders broadly, certainly mood disorders, exist along a spectrum or continuum. And the way I think about it, which is not unique to me, this is, I think, a shared kind of perspective, is that the two major mood disorders, major depressive disorders, plural, and bipolar disorders, plural, are probably not totally distinct. Obviously, at the margins, there's overlap, but at the end of the spectrum, they're clearly very distinct. I don't think mania is the same thing as a major depressive episode. But what we've recognized, informed by phenomenologic research, clinical experience, but also some really deep science, is that these conditions are overlapping considerably at the genetic level, epigenetic level, and as well, these are conditions that are commonly encountered in clinical practice. So I think the mood spectrum or the continuum, if you will, recognizes that there's an imperceptible line between the various subtypes of major depressive disorders and bipolar disorders.
I totally agree with you, Roger. Human nature isn't carved so neatly by it seems, and it's I think both the fascination and the opportunity and challenge for our field to be able to really lean into the gray zones and the subtleties of how this continuum presents on a spectrum. And, you can see this play out in symptoms that have, like you said, historically been described, and even in the early days of the field and how it was developed, there was an observation that these mood symptoms didn't neatly fit into neat categories or boxes. And the symptoms play out in that way. Depressive symptoms can be, you know, uh, very much in the low mood, negative state, or negative valence, diminished interest or pleasure, slow physical, emotional reactivity, fatigue, loss of energy, recurrent thoughts of death. And manic and hypomanic symptoms may seem like they're positively valenced very often in the elevated, expansive mood state, inflated self esteem, talkativeness, flight of ideas, increases in energy or goal directed activity, activities that have high potential for painful consequences, and a decreased need for sleep. But then you've got the admixture of these phenomena: anxiety, distractibility, irritability, indecision, insomnia, agitation. All of these symptoms can fall along that continuum and be manifest right alongside each of these poles. And so I think there's an appreciation that bipolarity as a disorder isn't just an exclusive manifestation of all or none. And many patients with bipolar disorder spend more days in negatively valence mood states or even mixed states, if you will. So I think that it's very interesting to me to see our field move towards a more dimensional way of understanding phenomenology and appreciating that it's not always black and white.
Yeah, that's well taken, Manfred. I agree with all of that. And I think one of the externalities or the unintended consequences of having a diagnostic categorical definition is we have what I call diagnostic orphans. In other words, we have entities or phenomenologic presentations of mood disorders that don't fit neatly into these three categories. Some might say, well, this sounds very academic, but it's not academic because getting the diagnosis timely and accurate is critical for care planning, as well as other aspects, including not limited to risk assessment and selecting and sequencing the appropriate treatment. What's especially, I think, important about the DSM-5 TR, which has been updated fairly recently, as you know, ma'am, is the augmentation with additional specifiers like the anxious distress specifier, and going back about a decade or so ago, just over, the mixed features specifier. Not to get too lost in the weeds on this, what we know is that mood disorders are along a continuum. Bipolar disorders, for example, are quintessentially heterogeneous. And we as clinicians are trying to personalize the assessment, trying to better understand what explains the patient's presentation. Is it major depression or bipolar disorder? If it's bipolar, is it bipolar 1, bipolar 2? But our job is not done. In addition to ascertaining BP1, BP2, we want to know what are the specifiers? Why is that relevant? Well, because every individual is different. And there's a triangulation of evidence that indicates that if you are someone with bipolar depression, type 1, type 2, and you also are manifesting mixed features or anxious distress or both, that is a very different phenomenologic presentation, not just academically, but clinically meaningful in the sense that this presentation is much more likely to be severe, associated with many types of comorbidity like ADHD, drug and alcohol use. There are safety concerns that are amplified here, like suicidality. When the patient says to us, what's my chance for recovery? Well, that answer is very different. We know that mixed and anxious distress presentations take much longer to fully remit and to fully recover, and the risk of recurrence and chronicity are elevated. One final comment is that when it comes to treatment considerations, the first rule of medicine is don't hurt the patient. The next rule is try and do some good for your patient. And when it comes to mixed and anxious distress, harm could happen if we don't choose the right treatments. In other words, we know just based on pharmacoepidemiologic data that these folks quite commonly are prescribed antidepressants. That's an area we agree is probably not the right way to go. So there are very different safety considerations here. Let's start with safety. There's also very different treatment recommendations as it relates to these presentations. I like to use the phrase, Manpreet, deep in vivo characterization. We want to very much characterize the patient because these types of phenomenological specifiers in the DSM and nuances in our patient do guide my planning, my risk assessment, and certainly guide my treatment selection and sequencing.
That makes great sense. And I love the way that you ended with sequencing because it was a natural continuing to the point I was going to make about development and how development really illustrates very well the evolution of our understanding and our way of phenotyping phenomenology. Because some features, some symptoms are prodromes, or they precede, or they are hallmarks of something that's coming down the line like a full threshold manic episode. And children are a great example of diagnostic orphans. So you have this opportunity to understand just by looking and observing at children. 30, 40 years ago, we didn't believe that kids could get sad. Now we still doubt whether kids could get manic, but the whether the plausibility of that reality is true or not is not something we can deny. We can debate the frequency or the prevalence of it, but the fact remains is that these phenomena are observed across the lifespan, and unfortunately, and maybe related to the fact that we can actually observe these things more and more systematic ways because we have better tools to do so, and we're beginning to see it in younger populations. And what I think we're seeing are these examples of specifiers manifesting, these examples of dimensional symptoms that are essentially increasing the probabilistic conversion towards a manic episode that, if observed longitudinally, can be managed. So it's not just important for us to necessarily rush to a diagnosis, but to watch these symptoms and what they're are going to evolve to eventually. I mean, with the appreciation again that severity is on a continuum, you've got the mixed features specifier, you've got the melancholic specifier, atypical, catatonic, and psychotic, with mood and congruence and incongruence. So, this level of granularity and specificity are intended to help aid us in that diagnostic journey with our patients. And you do need to give some attention to the DSM-5 um, uh, uh, language and specificity, because we're going to be able to utilize that information to identify core symptoms like elevated mood and energy, and then also be able to look in similarly in the depressed phase with depressed mood or loss of interest, along with that companion set of symptoms that define an episode. And I think it's really important for us to not only get into the business of describing these specifiers, but also being in the business of really very clearly describing the episode that defines the current presentation, because we know that these conditions are episodic. So, what symptoms, given that framework, Roger, point towards a diagnosis of the mixed feature specifier?
Yeah, very well put, Manpreet. I agree with all of that. I think what I would say to my colleagues who are joining us is that I would encourage them to have a look at the DSM-5 TR and just have a look at the different definitions and the criteria in the polythetic lists for specifiers like anxious distress and mixed features. And just to put a bit of color on that, there are about 10 specifiers actually in the DSM as it pertains to what is the most common presentation of bipolar disorders, that being the depressive presentation. And in there, there are very precise mentions as to what is eligible towards the definition being met. Manpreet, I know you've heard me mention this before. The natural habitat of bipolarity, however, doesn't also read the DSM 5 TR. And I often talk about the four A's of anxiety, agitation, anger, and attentional problems. Those are features which are very commonly encountered in mixed anxious presentations that are not actually in the definition of mixed features for academic reasons, because those features of anxiety, agitation, anger, and attentional problems can affect both poles of hypomania, mania, and depression, so they didn't get included in the final cut. Nonetheless, I always encourage colleagues to ask patients about the four A's, and if positive, then to delve deeper into the deep in vivo characterization and see if they have features of mixed specifier according to DSM. And we know that DSM has made this very clear what those criterion features are. I think that, frankly, just to be very blunt about this, I think that most clinicians recognize the importance of the psychotic specifier, mood congruent, mood incongruent. I think everyone asks patients about that. I don't, and this is just me biased by seeing residents. I work in an academic facility. I don't see as often people asking about mixed features and anxious distress. I think the takeaway message is we should, because it does matter. It matters with respect to what we talked about a moment ago, that is personalizing the assessment, personalizing the care plan, and on the granular level, being able to select and sequence treatments that don't harm the patient and select and sequence treatments that can be more potentially beneficial.
Yeah, no doubt about that. And really what's interesting to me is perhaps the evolution from DSM-4, where there were mixed states defined towards DSM-5, where you now have mixed features defined, it almost opened up the door, Roger, to us being able to do that work
Right.
of making sure that we evaluate for mixed features because that phenomenology is so common for so many patients who live with these disorders, to have some almost signal to remind us that we have to think about additional features. Dr. Singh, I often hear from my patients, I cannot function right now because of my anxiety. You've helped me mood stabilize, but there's still some significant anxiety that's keeping me up at night. These might be comorbid conditions, but again, we've got to figure out how to delineate mixed feature specifiers even from full on other comorbid conditions. So it's not easy, but I do like to tell my colleagues that it is okay to use guidelines and use a patient driven interview to help you think about the possible differential diagnosis. And it can then cue you up to understanding what are the horses and what are the zebras in terms of presentation. And if we know that mixed features are common, then we should surely be asking about them. And then I think you've added in recent years, thinking about anhedonia and some other really atypical symptoms that are almost a marker of treatment non-response or resistance, and make us really pause and think very carefully: what are we seeing in our patient that we're not adequately treating with the current armamentarium that's available?
Memory, absolutely, and well summarized. I think, first of all, we're going to agree that there is a continuum as it relates to depressive and bipolar disorders. But be more narrow, I think the word for me is heterogeneity. These are quintessentially heterogeneous conditions between individuals, but also within the individual across time. Manpreet has a developmental perspective and sees that firsthand, that phenomenological change across time. And I think for me, when I think about, for example, bipolar disorders, in addition to being highly heterogeneous, it's important for me as a clinician to be thinking, how can I personalize the assessment? In other words, how can I understand the patient's presentation in a way that really positions me and my patient to have a clear line of sight with respect to short term or more near term prognostication, but also long term care planning? And the mixed features anxious distress specifier are two specifiers of 10 specifiers in the DSM 5 TR that really encourage us to recognize the heterogeneity, but to really sharpen our focus as we assess patients, such that we then say, okay, you have this presentation informed by these specifiers. Guess what? If they're present, if they are present, that's going to change the way we think about, or may alter in some way the way we think about some of the selection and sequencing of treatment. What we want for our patients is treatments that are more bespoke, more personalized to them, and that's informed by these important phenomenologic characteristics that Manpreet and I are discussing here today.
So there are lots of consequences to having mixed features that I think we are all beginning to identify. Almost a third of patients meet criteria for mixed features during an index major depressive episode as part of major depressive disorder, bipolar 1 disorder, and bipolar 2 disorder. So it's a common phenomenon, as we had mentioned before, and it has psychosocial workplace impairment. Patients often have to miss work or school academics because of mixed features. Hospitalizations are often triggered by mixed features, and endorsement of suicidality. There's a higher rate of substance use disorder in bipolar disorder, but not in major depressive disorder and ADHD, which lends itself to exposing us to the possibility that mixed features has differential impacts on different disorders. So we got to get the diagnosis right, and we have to understand the impact of mixed features. And there's a high rate of cardiovascular comorbidity as well in the context of mixed features. So if we know that this is going to be consequential. How would we treat our patients differently, Roger, if we know that mixed features are present? You've mood stabilized a patient, or you've got a patient maybe on an antidepressant. What would you do next?
This is such a critical question, and you've summarized very nicely, Manpreet, some of the clinical implications of mixed features and or anxious distress, especially in the depressed patient as presenting as part of bipolar 1 or bipolar 2. What I might add to that, then keep the theme of clinical implications going. In this case, that is, in the case of mixed features and or anxious distress being present, I think what we're prescribing is important, but it's also important what we're proscribing. Proscribe means don't do it. And in other words, the antidepressant prescription in this case is highly discouraged. And unfortunately, it's quite common practice. It makes sense because people are depressed or anxious. So our instinct is give them an antidepressant. I have that instinct too. But we have to sort of hold the instinct or block the instinct or try to override the instinct because it turned out that's not the way to treat this presentation because it can contribute to worsening or amplification of the symptom severity. So I think in this case, I start off with what not to do. And then secondly, we now have at our disposal FDA approved treatments for the depressive phase of bipolar that have been shown to have some beneficial effects in the depressive phase, BP1, BP2, on these aspects that we are talking about here today. And importantly, giving people an opportunity for a improvement, a response, a remission that's meaningful to them as part of the depression presenting with mixed features and anxious distress. So I think that for folks who are, uh, maybe bipolar disorder is one of many, many conditions that they treat. Um, Bipolar is one of those conditions where it's these details are going to matter because there are such stark differences between treatments. Some can be hazardous, and others have been more studied in this particular presentation.
Well, thank goodness we have newer treatments that are here to meet patient unmet needs and iterate towards better. Because before that, we didn't have these options. And so we're lucky now to be able to think, if not antidepressants, then what else? And what else can we do is now beginning to be really an opportunity for us to look at other agents and newer medications that are US FDA approved for the treatment of the bipolar spectrum and even mixed features in the presence of a major depressive disorder. So, thanks for that.